In Mood 2, I want to talk about how mood disorders might arise around death, dying, and babies. We're going to start off with Kubler-Ross, 5 stages of death and dying. We're going to talk about some of the differential diagnoses you don't need to consider when you get a question about this, but we'll talk a little bit about how they can fit into the overall picture. I'm going to spend most of the time comparing grief against depression, and then we'll finish off with the postpartum disorders. Let's start off with Kubler-Ross's death and dying. And there are 5 stages. The first is denial, depression, bargaining, anger, and acceptance. Now, even though I listed them in this order, it's important to realize a person can go in and out of these stages in any order. There's no stage 1 and then stage final. It's nice if you're in acceptance. That is, you know it's coming and you're ready for it. It's more challenging to deal with patients who are actively dying but haven't come to accept it yet. And you're not really going to get a vignette or a question about this, but you should know the stages of death and dying, because if you can identify what stage someone's in, you can give them what they need emotionally. It makes a big difference. They could throw a vignette at you and say, hey, I don't have cancer, even though they're riddled. It's denial. If they have depressed mood and anhedonia and they don't really want to deal with their disorder, well, that's depression. If they ask you for more time or say, what can I do, what's different, or they pray to whatever celestial being that they believe in for more time, that's bargaining. Trade places, maybe. Anger is yelling, screaming, acting out, lashing out. And acceptance is when you finally come to terms. But someone could start in acceptance and fall out. And it is for the dying. Right? This is the stages of death and dying. It is for the person who's actively dying, but also for the survivors. Both deal with these 5 stages within themselves and within each other. So that's an opening to death and dying and babies. And I want to talk about responses to stressors. Right? In the PTSD and related disorders, we talked about acute stress disorder and post-traumatic stress disorder, as well as adjustment disorder. I'm not going to bring these up again because while they're on the differential, they don't really play into how I want you to see these disorders or compare them to each other. PTSD can be in response to the loss of a loved one, especially if that loss was unexpected or violent. And remember, you can get PTSD just from hearing about how a loved one died. Learning that it happened alone is enough to stimulate PTSD. And both PTSD, bereavement, grief, depression will all have similar features: avoidance, not wanting to talk about it, trying not to go to the scene or the location. But the primary response in PTSD or acute stress disorder, these are the same disorders with different durations of symptoms, the main thing of PTSD is fear and anxiety. Whereas in grief and depression, it's depression. Adjustment disorder was a non-life-threatening stressor, so let's call it a mild stressor, causes some change in mood that didn't meet the criteria for another disorder. But if you look in the DSM-5, by definition, adjustment disorder cannot be defined by bereavement, which means that if we're comparing grief to depression in the period following the loss of a loved one, bereavement, can't be adjustment disorder. So it's probably not going to be PTSD, but look for anxiety and fear and violent death, might be. Adjustment disorder can't happen in death and dying. But what I do want to do is spend a good amount of time comparing the difference between regular, normal, uncomplicated grief against what it looks like in major depressive disorder. We've thrown in an extra diagnosis to make things more complicated. Formerly called complicated grief, we now have persistent complex bereavement disorder. What I want to do is compare grief and depression and show how BCBD is just a mishmash of the two. Before we get started with this, Grief is normal and doesn't need to be treated. Grief is often focused on the loss of the person. The symptoms, the desires, the thoughts of suicide, everything focuses on the deceased. When it is depression, the focus is on the patient themselves. Their symptoms are pervasive and are eating into the rest of their lives. They're hopeless, there is no future, they are depressed. In grief, they're upset. It's okay. They lost someone they care about, but they have a future and they have a life. We'll see how this plays out. We're going to compare these diseases based on the onset, the duration, and then what the focus is on, right? In all of these disorders, we're going to feel dysphoria, depressed mood. We're going to feel guilt, and we're going to feel anhedonia. But what the focus of these things is on is going to determine grief versus depression. You can also consider when the person has their depressed mood and how often. What are normal behaviors? And these are going to be categorized by culture, but I'm going to show you the Western US version because that's what we're studying for. And even though there's suicide could be a consideration, why the patient wants to commit suicide is a big part of separating grief from depression. And finally, what are you going to do to treat it? Grief, you don't treat. You might offer counseling or a shoulder to cry on, but you don't need to medicate. PCBD and major depressive disorder are bad enough where you want to use antidepressants, SSRIs and SNRIs. So it's not going to be an issue of how do you treat this? It's going to be an issue of is it grief or is it depression? The duration and onset is a little challenging, and I recommend you don't use that as a diagnostic criteria, especially for a test. It has some parameters, but it's likely not to help you. Grief onset can be at any time. It's usually close to the event, but grief is normal in a bereavement period up to 1 year. That is, so long as these symptoms have not lasted more than 12 months, their duration is less than 12 months in duration, it is normal. And usually that means 12 months since the loss of the person. Major depressive disorder can have its onset at any time. But if grief has gone on for more than 12 months, you start thinking about major depressive disorder. But now there's this persistent complex bereavement disorder that has symptoms that last for 12 months. But to be persistent, the symptoms had to have started 6 months after. That 6 months came from the old definition of grief, which was 6 months in duration. So be careful using the duration stuff because I don't think it's going to help you. Just know that normal grief moved from 6 months is normal to 12 months is normal, and persistent bereavement disorder, prolonged grief, now begins when normal grief ends, 12 months. Okay, where you should focus your attention is on what we're going to talk about now, below the dashed line here and above the treatment line. All right, let's talk about grief first. There is depressed mood. They miss the person. There is guilt. What could I have done differently? How did I leave that situation? What could I have done to keep them here? There is anhedonia. I used to love go ice skating. Now I can't go ice skating because she's not there. All of those things are normal as long as they're focused on the deceased. And just like that, grief can have depressed mood. The mood can change. The depressed mood waxes and wanes. And they can imagine a time in the future where they will be happy. Or they might spend time with friends and family and be happy. But then when they're alone, they get sad, they miss the person that's gone. Or they come upon a location that triggers a depression reaction. But when they're away from the trigger, they do fine. And some behaviors which might sound like they're becoming psychotic aren't. They're normal. Be careful to pay attention to the preposition. Things like talking to the deceased. You know they're not there. You're not having a conversation, but you're still talking to them as though they are. Praying at them. Not expecting a response. Visiting the gravesite. Even seeing them in the crowd is okay. The glimpse. But there is insight. You know that they're gone. You know they're not coming back. You know that they're not going to communicate with you. And as you look over the crowd and you think you saw someone under the corner of your eye that looked like her, you realize it's not. She's gone. Suicide and thoughts of suicide are normal in grief. Again, if the focus, the reason to commit suicide or to die is for the deceased, that's a normal part of grief. I want to be with them again. I wish I could trade places, take me instead. Those things are normal in grief and don't need to be hospitalized or medicated. Let's contrast that with major depressive disorder. In major depressive disorder, there is guilt, dysphoria, anhedonia. But now, instead of focused on the deceased, it is pervasive. And it is global. It eats into the rest of their life. They don't want to do anything. They feel bad all the time. They feel guilty, not just about the relationship, but about everything. Signs of depression, Siggy Cabs positive. They have a depressed mood, but it is persistent. Not only is it pervasive, it is also persistent. And they cannot imagine a time in the future where they could be happy. They're hopeless and despondent, trapped in these negative emotions that are pervasive throughout their entire life. And the behaviors are going to be in relation to hallucinations. They could be auditory, that is, they are talking with the deceased, or they could be visual, where they see the deceased. These are on the order of psychotic disorders, right? They have psychotic features. And usually people with psychosis lack insight. Looking out across the crowd, catching a glimpse of her, but it's not her. Sitting at dinner, setting a plate, having dinner together while she converses what it's like to be up in heaven, that's psychosis. Catch her in the crowd, grief. And then the reason why they would commit suicide, what they're thinking about, is the self. They are despondent and hopeless. And the death will free themselves from it. It is a negative reflection of self, not of the deceased. Okay, barring duration and onset, PCBD has the focus of grief, the symptoms of depression. There are a long set of diagnostic criteria, one symptom for 6 months, numbness, despondent, wanting to be with them, blaming self, blah, 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 blah. You're not going to memorize every set of criteria for every disease. It's not possible. Most psychiatrists don't. And you're not going to be expected to. But what you should be able to do is know what's normal, what is obviously depression, and then if it's sort of in between, you're not sure, it's probably BCBD. And use the duration to only rule out grief, not rule in depression or complicated grief. That's death and dying. Let's talk about babies. 3 disorders we want to talk about: the baby blues, postpartum depression, where you can bet the mood symptoms predominate, and then postpartum psychosis, where the psychosis predominates. We're going to separate these diseases based on which baby it is and how mom feels about baby, what the onset is, how long it will last if you do nothing, what are the psychiatric symptoms, and how do you treat. Now, if you've already seen mood disorder lessons and you've seen the psychotic disorder lessons, this is going to be really easy. Baby blues. It is usually the first baby, and mom cares. She just feels down and is not really sure how to take care of baby, or she kind of feels in a rut, but she will take care of baby. The onset and duration are both within 2 weeks. That is, by the time mom brings in baby for her well-child visit, she's already gone through the symptoms and they're gone. She mentions that they happened. You don't have to do anything about it because the symptoms simply were depressed mood. She didn't meet criteria. This is effectively adjustment disorder that lasts not very long, and you don't have to treat it. Postpartum depression is usually after the first, and mom doesn't care about baby. Now, she might want it to live, but her depressive symptoms make her so disinterested and with lack of energy that she doesn't take care of it. That leads to neglect. The neglect is bad, but it's not mom's fault. Usually the onset is within 1 month, and the duration will be ongoing unless you get her out of it. Being postpartum depression, you're likely to find major depressive episode symptoms, SIGI CAPS, and the treatment is with antidepressants, SSRIs. Postpartum psychosis, that's the dangerous one. This is effectively brief psychotic disorder. It's going to usually be not the first baby, and mom fears baby and is likely to kill it. This is the most dangerous. This is how parents kill their kids and then end up not knowing why they did it in the first place. Onset is always within the first month of the stressor, of the birth, and if not treated, it will go ongoing. Being postpartum psychosis, you won't be surprised to find the psychosis predominates. And because psychosis predominates, we're going to use antipsychotics primarily to treat. This is simply saying we've renamed disorders and called the stressor delivery, and the patient happens to be mom. The good news is that these are very easily separated. It's effectively, if mom has depression after having a baby, it's depression. If mom has psychotic features after having a baby, it's psychosis. And if she just gets over it really fast, it was postpartum blues. You don't have to worry about it. This is pretty easy. It's basically, do you know depression and mood disorders? And do you know psychotic disorders? If yes, mom's taken care of. We're probably not going to see a question on Kubler-Ross's death and dying, so most of your focus should go towards determining, is this grief, focus on the deceased, or is this depression, focus on the self-pervasive? Treat and hospitalize depression. Let people who are grieving simply grieve. That's mood 2, death, dying, and babies.